Sir, kindly share your screen, sir.
Yeah, okay, perfect. Host disable participants screen sharing.
Now you can, sir.
Okay, perfect. So, yes, good evening, everyone. This side Dr. Abhijeet, and welcome to yet another session of this practical discussion in biochemistry, right? So today is day 2, where I will be discussing about the OSPE in the practical part of biochemistry, where I will be focusing on the performances, instruments, and charts over here, right? So I will be discussing all this over here in the OSPE part today, right? So yes, now, we already know that we have already initiated this rapid revision program, and we are all covering the important volatile topics in a very crisp, concise, and conceptual manner, right? It is beneficial for you as per my knowledge, right? Right now, practicals exams are like going on, and I want like it will be a beneficial aid for each and every student who is going to appear for this practical exam, right? From the first course. So yes, these are the topics I will be like focusing on today. Apart from that, guys, remember about the Oracle app, right? You already know we have the recorded classes, we have the live classes, we have the practical sessions, the exam module, and now we have this hard copy book set. Apart from that, the recorded classes, the live classes, express exam module, one-to-one doubt clearing session. The practical sessions also are recorded, right? And we have the question bank from beginners to know advanced level, covering all the important entire topics like from the last 10 to 15 years, all questions from the like in the NEET PG exam and FMG as well, right? So yes, this is the basic subscription plan, guys, that you can see that is displayed on the screen. Apart from that, guys, if you want some extra like discount, you can use my code Dr. Abhijeet 20, right? Now, guys, you already know over here, I will be like today focusing on the performances, right? We have the instruments and the charts, and that is total of these yeah 80 marks that we are going to now like focusing on today, right? So yes, these are the basic rules, guys, while you appear for the exam, right, the practical exam. So that is something you have to like the instructions mandatory for appearing in the practical exam, right? Now you have the various performance station, guys, where the university registration number will be there. Perform the test based on the station question, right? So we have to use the clean test tubes, use test tube holders, right? Perform the steps of the test as written in records, show the endpoint of the test to the examiner, right? And you have to know at least the basic knowledge of the composition of reagents, principle of the test, and its clinical significance. These are like the key points that you have to like remember. Now, okay, you have to write the name of the test at the performance station, but there's no need to write the principle or procedure of the test. For quantitative performance station, OD calculation and final value has to be written, right? Now, guys, before coming on to these parts, let us first discuss. Yeah, let us first focus on. Okay, I will be discussing the charts first. I will be discussing the charts first. Then I will be going to other parts because yeah, the charts are like the very important like over here. So we are going to discuss jaundice charts over here. Now the question says that a 36-year-old obese female complains of pain in the right abdomen, yellow discoloration of eyes, passing clay-colored stools, and developed intolerance to oily food for past 1 month. Her investigations are given and they have asked the probable diagnosis. Now the probable diagnosis, guys, over here it is written, it is obstructive or post-hepatic jaundice. Now, guys, what are the key indicators, guys? You have to remember it is already given in the question that there is pain in the right abdomen, right? We have the pain in the right abdomen. There is yellow discoloration of the eyes, right? Yellow discoloration of the sclera, okay, indicates jaundice, guys, right? Okay. Whenever there is a pain in the right abdomen, guys, remember it suggests the potential issues with the liver or the biliary system. Now, when it's passing like clay colored stool, it clearly indicates, guys, that it lacks. Okay, it commonly indicates, guys, how do we clinch the diagnosis? It indicates lack of bilirubin, reaching the intestines, reaching the intestine, and that could be due to, yes, obstruction of the bile ducts, and that could be due to obstruction of the bile ducts, right? And obviously it is going like, okay, we have like three types: pre-hepatic, hepatic, and post-hepatic. That's why we have said post-hepatic. Okay, we have the hepatic, that is liver. Beyond liver, we have these bile ducts, and there is obstruction of bile ducts. That's why it is post-hepatic jaundice or obstruction, because bilirubin is not reaching the intestine. That's why clay-colored stools are there, right? Okay, and intolerance to oily food. Again, they are giving intolerance to oily food. So basically, it suggests some problem related with the bile production or secretion. Okay, there is some production related with the bile production or secretion. Now, guys, so the first question answer you have already know, it is obstructive or post-hepatic jaundice. Obstructive or post-hepatic jaundice. Now, the second question says the lab findings, guys. Okay, yeah, okay, principles of Vandenberger test. Yeah, I'll be just, yeah. So firstly, you should know the normal values of total bilirubin, direct bilirubin. Yes. So you already know the total bilirubin is 10.5. Okay. So that obviously will indicate jaundice. Yes, it is elevated, guys. Yes, it is elevated. We have high conjugated bilirubin, that is 10. So it points towards the obstructive jaundice, since conjugated bilirubin is water soluble, guys. Okay. And it increases in the bile duct obstruction. Okay. Obviously, we have already talked about serum ALP. It is also increased over here, right? It suggests, okay, it suggests cholestasis, right? Or obstruction of the bile ducts, right? So that is something you have to remember over here. Okay. Now, name the marker enzyme for, yes. Okay. Now, firstly, let us just try to discuss what is the Vanderbergen test, or yes. Now, okay, let me just write it over here. So we are now discussing the same. First question is done. The answer is obstructive or post-hepatic jaundice, and I've given you the reason why. The question number 2, what is the principle of Vandenberg test? Let us just try to write it. What is the principle of Vandenberg test? Vandenberg test. Now, guys, it is also known as Vanderberg reaction. It is also known as Vandenberg reaction, guys, right? Or it is also known as Vanderberg bilirubin test. Okay, it is also known as Vandenberg bilirubin test. Bilirubin test, right? So basically, this test is used to detect bilirubin in urine. It is used to detect bilirubin in the urine, right? Now, guys, remember the principle is based on the reaction of bilirubin. No, we have bilirubin with a reagent to form a colored complex. Okay, to form a colored complex. In this test, beta, remember the urine is mixed with reagent containing diazotized sulfanic acid, okay, which reacts with bilirubin to produce a color. Okay, and the presence of this color basically indicates a positive result for bilirubinemia. bilirubinuria. Bilirubinuria. Okay. So remember that over here, the principle it is based when the bilirubin, it is basically reacting with a reagent containing diazotized sulfanilic acid. Okay, the urine is mixed with that. And after that, basically the bilirubin, urine containing this reagent, and obviously a color will be produced that indicates a positive reaction for bilirubinuria, right? Now, coming on to the next question, guys, they're asking the normal values of total bilirubin and direct bilirubin and ALP. Now, question number third, beta. Total bilirubin, beta, remember it is 0.1, okay, to 1.2 milligram per deciliter. And you can very well see over here it is 10.5. So it is automatically increased, right? It is automatically increased. We have another, okay, they have asked for direct or conjugated bilirubin. Direct means conjugated bilirubin. And over here, guys, remember it is 0.1 to 0.3 milligram per deciliter, right? And you can again see the direct or the conjugated bilirubin is also increased. And we have alkaline phosphatase. And remember it is 44 to 147 international units per liter. And over here, you can again see it is 580, it is increase. So these are the total three normal values that you have to remember. Apart from that, they're asking the marker enzyme for alcoholic liver disease. So remember, guys, it is gamma glutamyl transferase. Okay, that is GGT. Very, very important. What is the answer? The marker enzyme for alcoholic liver disease, it is gamma glutamyl transferase, that is GGT. Elevated levels of GGT, guys. Again, an important question. If there are elevated levels of GGT, okay, it is often alongside, okay, along with it, basically we have the AST, that is the aspartate aminotransferase. If AST, GGT basically and ALT, basically they all the elevated like case these levels are seen in alcoholic liver disease. Again, GGT, AST and ALT. Okay, alanine aminotransferase, all these levels are commonly elevated in alcoholic liver disease. So that is one of the case that you have to remember. Okay, if we are in, now we have discussed one of the cases over here. Now coming on to the next one, guys. Yes, the next case over here in the jaundice chart. Yeah. No. A 30-year-old man was admitted to a hospital with complaints of vomiting, fever, and abdominal pain for the past 1 month. Yellowish discoloration of eyes and skin were, yes, noticed, and investigations are as follows. Right? Now, the total bilirubin, guys, we have just seen from the last question. We have just seen from the last question the total bilirubin, the direct bilirubin, basically everything is increased over here. Now, the very first question, what is the probable diagnosis, guys? Now, this is, yes. Yes, this can be hepatic jaundice, guys, but more or less, yes, the more or less over here, just try to remember it can be acute viral hepatitis and yes, acute viral hepatitis. And it can be due to hepatitis either A, B, or C, right? It can be due to either A, B, or C. So basically the key indicators, guys, you already know we have the total bilirubin, which is increased, right? So it indicates jaundice, right? Now, elevated serum bilirubin, guys, okay, that is the direct bilirubin, that is 7.5. So it indicates conjugated hyperbilirubinemia. Okay, there is hyper means increased bilirubin, emia means blood. Okay, it is conjugated hyperbilirubinemia, right? typical of hepatitis. Okay, it is typical of hepatitis. It is typical of hepatitis, guys, right? Now, we have, if we just focused on the other parameters also, elevated ALT, guys, you can see. Yes, and elevated AST also you can see. Both the parameters are increased. Okay. ALT increased, it is basically a hallmark of acute hepatitis. Okay, it is a hallmark of acute hepatitis. Okay, right? ALT is more specific to liver damage than AST, guys. So extremely high ALT, guys, extremely high ALT as compared to AST also support like the hepatocellular injury. So the probable diagnosis over here, it will be acute viral hepatitis. Vandenberg test we have already discussed. Yes, mixing the urine sample with a reagent containing diazotized sulfalinic acid, and bilirubin reacts with the reagent to produce a colored complex. Usually it is a pink or a red color, right? And the presence of the color indicates bilirubinuria, okay, which is a sign of conjugated hyperbilirubinemia. Right now, the normal levels of total bilirubin we have just discussed, it is 0.1 to 1.2. Direct bilirubin, you already know it is 0.1 to 0.3. And AST, it is, yes, you have to remember AST over here, it is 10 to 40 international units per liter. Over here, you can see it is like, yes, the AST, it is 580, it is significantly very, very elevated. Right now, the marker enzyme for the alcoholic liver disease, the question that they have asked. Remember, guys, the marker enzyme, it is again the same, that is GGT, gamma glutamyl transferase, right? So basically, elevated GGT along with the levels of no elevated AST and elevated ALT. Basically, they are all commonly used to diagnose the alcohol related liver damage, right? So that is about the second jaundice chart that you can remember on the basis of the values provided, right? So we have discussed two cases. Now coming on to the next one, guys. Yes. Now, the question says a 24-year-old chronic anemic female patient who had blood transfusion 4 times in the last 20 days complained of passing dark colored urine. Her investigations are as follows. Total bilirubin is given, conjugated, unconjugated, alkaline phosphatase, AST, ALT. Even bile salts and bile pigments in the urine are negative. Now, what is the probable diagnosis, guys? What is the probable diagnosis? Yes, it is hemolytic or pre-hepatic jaundice. Yes, it is hemolytic or pre-hepatic jaundice. Right? So obviously, again, the second question again remains the same, the principle of Vandenberg test. Again, it is from the last question. The levels again remain the same and the marker enzyme will again remain the same, guys, right? Now, guys, coming on to the next question. The next question says that an 8-year-old girl is brought to OPD with complaints of dryness of eyes and difficulty of vision in evening and at night. She also complained of diarrhea and recurrent infections. On examination, she looked weak, malnourished, and her skin was dry and rough. Examination of eyes showed dryness of cornea and brownish spots on the sclera of the left eye. There was no other finding. Dietary history reveals that she had cereals, pulses, processed foods in diet, and very little milk, fruits, and vegetables. Clinician made the probable diagnosis of night blindness with vitamin A deficiency. Now, again, they have already given you, or you don't have to clinch the diagnosis in this question. They have already given you the diagnosis, that is vitamin A deficiency or the night blindness. Now, name the active forms of vitamin A with their function. Now, they're asking name the active forms of vitamin A, yes, and their functions. First one, you have to remember retinol, right? So retinol basically is the active form of vitamin A, and remember it is involved in vision. Yes, and particularly in the formation of a pigment called as rhodopsin. You already know a pigment in the retina that is crucial for the low light or the night vision, right? Rhodopsin crucial for low light, or we also call it as the night vision, right? It also plays a role in cellular differentiation and immune function, okay? Cell differentiation and immune function, right? Apart from that, the other active form of vitamin A that you can remember, it is, yes, retinal. It is retinal, guys. And remember, guys, the retinal, it is component of rhodopsin only. Component of rhodopsin in the rod cells. In rod cells of retina, right? Now, this retinal, remember, it is responsible for a process called as phototransduction process. Okay, phototransduction process. And you guys already know what is the phototransduction process. It converts light. Okay, it converts light into electrical signals, guys, right, in the retina, enabling vision, particularly in the dim light, right? We have one more active form of vitamin A, guys, that you can remember, that is the retinoic acid. Retinoic acid, okay? So retinoic acid is basically involved in gene expression and cellular differentiation. Gene expression and cellular differentiation, guys, okay? It regulates and maintains the epithelial tissue, right, including the skin, the mucous membrane, okay? And it's also plays an important role in the embryonic development as well. So that was regarding the first question. You have to write all the active forms and their functions as well. That's a part like 4 marks. You have to write all the three along with one line. You can mention the function as well, right? Coming on to the next question, name the sources of vitamin A. Name the sources of vitamin A, guys. So you already know we have animal sources. Animal sources, right? You already know in animal sources, we have the dairy products. The dairy products, that is milk, cheese, butter. We have eggs. We have liver, right? Of like beef, chicken, etc. The most important one, the fish oils, okay? That is the cod liver oil, the cod liver oil, right? Apart from that, we have like plant sources also, guys. We have plant sources, and you already know they provide provitamin A. And that is the very first one that you should know, the carrots. We have the sweet potatoes, that is again sweet potatoes. Yes. We have spinach. Yes. Also mangoes. Okay. And we have like butternut squash also, right? Now, the third question that they're asking, what is provitamin A and what is its function? Now, guys, remember provitamin A, it is also referred to as beta carotene. Beta carotene, which is a carotenoid found in plants, okay? Plant-based foods, right? It is a carotenoid which is found in plant-based food. Now, what is a function of this? So this beta carotene basically acts as a precursor to vitamin A. Precursor to vitamin A. It is converted into retinol. Okay, it is converted into retinol. That is the active form of vitamin A in the body. So remember, guys, the beta carotene has antioxidant properties, guys. Again, very, very important. It has antioxidant properties that helps the cells know, that helps protect cells from the damage, right? It also contributes to maintaining the healthy vision, right? The skin and even the immune function. So that is regarding the vitamin, guys, that you can remember over here. Okay. Now coming on to the next question. Okay. The question is, a 4-year-old boy was brought to pediatric OPD with history of delayed milestones. He started walking late at 2 years of age. On examination, the child's growth was retarded. He looked malnourished. The limbs had poor muscle tone. His legs looked bowed, and there was knocking of the knees during walking. What is the likely diagnosis? Okay, the likely diagnosis, guys, over here it is the rickets. It is the rickets, guys. How you can just see. Now the very first one, guys, it is, yeah, delayed milestones. Okay, like for example, it's already mentioned in the question. It is walking later than expected. Okay, so that is one of the thing. Growth retardation. Again, growth was retarded, right? Malnourished appearance and poor growth. Okay, even the poor muscle tone, the limbs have a poor muscle tone, guys, right? So indicates skeletal abnormalities over here. Okay, they're pointing towards the skeletal abnormalities. Abnormalities. So that is something which you can just relate it over here. And second question is, what is the biochemical basis of this disease? What is the biochemical basis? Now, you already know the rickets, basically it is caused due to a deficiency in vitamin D. Deficiency in vitamin D, calcium or phosphate, right? The vitamin, I mean, the biochemical basis basically includes vitamin D deficiency. Now, vitamin D, it is basically responsible, guys. It is basically responsible for the absorption of calcium and phosphate from the gastrointestinal tract. You already know the vitamin D, it is responsible for the absorption of calcium and phosphate from the GIT tract, right? A deficiency of vitamin D3, okay, or a deficiency leading to like calcium or phosphate deficiency in the blood. Again, right? Vitamin D is deficient. Obviously, it will not be able to absorb calcium and phosphate coming from the diet. Again, if the calcium and phosphate are not absorbed, right, what will it lead to? There will be low levels of calcium and phosphate in the blood, right? Now, with low vitamin D levels, with low calcium levels, with low phosphate levels, the body cannot absorb enough calcium and phosphate. Okay. Now, what will happen if there is no calcium, guys? You already know there will be decreased mineralization of bone matrix, right? There will be decreased mineralization of bone matrix, and it will be resulting in soft and weak bones. Soft and weak bones, right? Soft and weak bones, right? Soft and weak bones, right? Now, okay, so that is you have to remember, right? Now the third question says, how does sunlight help in preventing the disease? Now, you already know sunlight basically helps in preventing rickets through the following mechanism. And which mechanism, guys, it is, you already have to remember. It is called as the vitamin D synthesis. Vitamin D synthesis. Now, let us discuss this third question over here also. Hmm. Now, vitamin D synthesis. So the sunlight helps in preventing rickets. Sunlight helps in preventing rickets, okay, through the following mechanism, and that mechanism, it is vitamin D synthesis. Now, what happens? Sunlight exposure, guys. Sunlight exposure stimulates production of vitamin D, okay, in the skin, okay, and you already know ultraviolet B, or I can say UVB radiations from sunlight, okay, from sunlight, what it will do, it will convert 7-dehydrocholesterol, okay, which is like present in the skin to form vitamin D3. Okay, that is called as polycalciferol, right? So what one synthesized vitamin D, guys, you already know it is converted in the liver and kidneys to active form, that is called as calcitriol, right? Calcitriol, that is the active form of vitamin D. Active form of vitamin D. And calcitriol is something which will enhance absorption of calcium and phosphate from the gut, GIT gut, right? So it will support proper mineralization and it will help in preventing rickets, right? So that is again this vitamin D deficiency that we have already discussed, all the three questions. Coming on to the next case study, guys, the ABG graphs are important. The charts, the ABG, acid base gas, right? The acid base disorders we are going to discuss right now. And one over here, it is, yes. Now, the question says a 35-year-old male who is a known chronic alcoholic, okay, heavily intoxicated with alcohol and admitted in the emergency ward in a comatose stage. Now, the patient is heavily intoxicated with this alcoholic part. And now you can see that the patient is already like in a coma stage. Now they have given the pH that is 7.2, bicarbonate that is 23 milliequivalents per liter, and PCO2 that is 50 mm per Hg, right? Now, if they have asked two questions over here, identify the acid-base disorder. Just try to look at the pH, guys, the pH. Now, basically, it is like slightly lower than the normal pH, guys. Okay, it is slightly lower than the normal pH, right? So you should know that it is acidemia, right? Lower than the normal pH. Bicarbonate, it is 23. Now, guys, bicarbonate, you already know it is 22 to 26 milliequivalents per liter. 22 to 26 milliequivalents per liter.
99.
हाँ दे दो एक. 22 to 26 milliequivalents per liter. Now, you can very well see it is like 23. So it is not normally altered. It is, I will basically say it is normal, guys. It is normal. Now, when I say PCO2, guys, you already know it is slightly increased. The normal values, the normal PCO2, guys, it is approximately, you already know, 35 to 45 mm of Hg. 35 to 45 mm of Hg. And basically, if it is increased, guys, if you can see it is increased, it automatically tells that there is an increase in the carbon dioxide levels. There is increase in the carbon dioxide levels. Now, the pH is low, we have acidemia, okay? The bicarbonate is normal, so remember that there is no metabolic compensation over here, right? It is not evident over here. And elevated PCO2, guys, it suggests that the respiratory factors are contributing to acidemia. The respiratory factors are corresponding to acidemia. And remember, the primary acid-base disorder here will be, yes, respiratory acidosis. Obviously, PCO2 increased and pH slightly decreased. Respiratory acidosis. Acidosis, very, very important. So you have to first clinch based on the given information, and then you have to like mention it as respiratory acidosis. Now, if we just see what they have given, yes, it is respiratory acidosis only. Now, they have asked a second question, guys, right? Any two conditions causing the above disorder. Now, the very first one that you have to remember, guys, over here, we have acute respiratory failure. We have acute respiratory failure. And remember that basically what happens, conditions basically that will impair the lung activity, the lung ability to expel CO2. Okay, such as like chronic obstructive pulmonary disease. You already know the COPD, okay? Exacerbation or acute respiratory distress syndrome, ARDS, can lead to respiratory disorders. These are very, very important conditions, guys. Chronic obstructive pulmonary disease and acute respiratory distress syndrome, okay, can lead to respiratory acidosis. These are both parts of acute respiratory failure, okay? Now, in the context, basically the chronic alcoholism, you can obviously see over here the main person is alcoholic, heavily intoxicated with alcohol, guys. You can remember that it can depress the central nervous system. It can depress the central nervous system, impairing the respiratory drive and leading to CO2 retention in the body. CO2 will retain in the body, not be able to expel out, and thus it will lead to respiratory acidosis. Second condition, yes, obviously it is the CNS, central nervous system depression, guys, right? So depressants, basically over here in the question, it is given as alcohol. It can suppress the respiratory center in the brain. It can suppress respiratory center in the brain, guys. Very, very important, right? Leading to hypoventilation, leading to hypoventilation. So there will be decreased breathing rate or depth, which will cause CO2 to accumulate inside the body, okay, resulting in respiratory acidosis. Even if a patient is consuming alcohol for a longer duration, like chronic alcohol consumption can lead to respiratory depression as well, right? So yes, that is you have to remember over here. Now coming on to the next question, guys. Yes, they have given a 50-year-old non-diabetic male patient admitted in the emergency ward with dizziness and abdominal pain. Now you can see the random blood glucose levels over here. It is 521. Can you see it as how much it is significantly like elevated, guys, over here, right? It should be like less than 150 to 200, right? It should be less than 150, and you can see it is like 521. So it automatically indicates that it is hyperglycemia. Hyperglycemia. Hyper, more glucose in the blood, more glucose in the blood. pH is basically 7.36. It should be like, yeah, 7.4, slightly lower than the normal pH, guys, right? So it is acidemia, guys, which you can see, acidemia. HCO3, it is like 14 milliequivalents per liter. And as I told you, the normal it is 22 to 26. You can see the bicarbonate levels are decreasing. So that will be metabolic acidosis. Metabolic acidosis, obviously the bicarbonates levels are decreasing. And PCO2, it is 15 mm of He. And you already know PCO2, normally it is, I've already told you, 35 to 45 mm of He. So it is also decreased, guys. It is also decreased. So there will be respiratory compensation. Okay, there will be respiratory compensation for metabolic acidosis. So yes, if we take the anion gap, guys, anion gap, it is 18. And remember, guys, the normal anion gap, it should be between 8 to 12 millimole per liter. Over here, it is 18. Over here, if you see, it is 18, guys. It is 18. So it is increased anion gap. It is increased anion gap. Now the acid-base disorder, guys, yes. If we just focus over here, let us just try to figure out the low pH and low bicarbonate. Low pH and low bicarbonate, it indicates metabolic acidosis, right? Elevated anion gap, guys, may suggest high anion gap metabolic acidosis, right? So yes, increased anion gap along with metabolic acidosis can indicate high anion gap metabolic acidosis. And low levels of CO2, guys, low levels of CO2, it indicates compensatory respiratory alkalosis. Respiratory alkalosis. So yes, over here, the answer, it will be, guys, the acid-base disorder, it is high anion gap metabolic acidosis. Metabolic acidosis, right? And now they're asking the second question, mention any two conditions causing the above disorder. Okay, let us just try to see over here what they have given. Yes, it is metabolic acidosis only, guys, right? They have already given fully compensated. I have already told you it is compensatory respiratory alkalosis, right? So yes, obviously the two conditions which can lead to the above disorder, it is diabetic ketoacidosis. Diabetic ketoacidosis. It is a common complication of diabetes. We have already discussed the starvation, diabetes, and all that. Okay. With severe hyperglycemia, guys, it's already 521. It should be like below 200, below 150. It's severely increased, guys. What will happen? It results from a lack of insulin, guys. It will lead to the production of keto acids. We have already told there is so much of glucose in the blood, but it is not in the cell. Due to prolonged fasting, what will happen, guys? Yes, in the starvation state, obviously it is depleted. The cell is not getting glucose from anywhere. All the gluconeogenesis is also depleted. Now, obviously, it will be leading to the formation of, this acetyl coenzyme A, which will be formed. It will be like going to form the ketone bodies. And yes, that is called as the, yes, this diabetic ketoacidosis. You will also get elevated blood glucose levels, elevated anion gap, low bicarbonate levels, and possible ketonemia or ketonuria also you can get over here. Other condition, guys, you can just remember over here, we have lactic acidosis also. Lactic acidosis also. Remember, the lactic acidosis, guys, occurs when there is accumulation of lactic acid in the blood, right? And you already know, the lactic acidosis. I have already told you, whenever there is anaerobic glycolysis, like guys, when you are exercising too much, when the skeletal muscles are exercising, or there is hypoxia, decrease in oxygen levels, or if there is shock means the low blood pressure less than 60, the systolic blood pressure goes. It can all lead to this lactic acidosis, right? So that is something you have to remember, right? So yes, the two conditions over here. And you have to explain this, right? Now, coming on to the next one. Guys. The next question says that the following is the ABG report of a case of a suspected poisoning who has been given nasogastric suction at first aid measure. pH is 7.5. Now, guys, when I say pH, you already know it is slightly higher than the normal pH. So it can indicate alkalemia. Okay. Emia means blood. Bicarbonate levels, guys, you already know normal it is 22 to 26 milliequivalents per liter. Over here it is given 36. So remember, guys, it indicates the primary metabolic alkalosis. And PCO2 is 35, guys. Okay, normal, 35 mm of Hg. Normal, okay. Beta, it's absolutely normal. It is between 35 to 45. Basically, it's like minimal like respiratory compensation is there. It's absolutely like I'll consider it as normal. Identify the acid-base disorder. It is the metabolic alkalosis, guys. The metabolic alkalosis. Now, the conditions that can cause the above disorder, the very first one, remember the gastric acid loss. The gastric acid loss. Now, when I say gastric acid loss, guys, you already know one thing over here that you already know we have the nasogastric suction. Okay, as mentioned, it removes gastric acid. Okay, now over here in the question also, it's giving a hint, guys, over here, nasogastric suction. So it removes gastric acid, that is HCl, from the stomach, right? The loss of hydrogen and chloride ions from the gastric secretions lead to a relative increase in the bicarbonate, okay, causing metabolic alkalosis, right? So that is something you have to remember, the elevated bicarbonate levels, normal or slightly elevated PCO2, right? And history of gastric suction or vomiting, guys, whenever there is a loss of these hydrogen or chloride ions, obviously they are going out of the stomach, so this will lead to this metabolic alkalosis. Again, we can have one more cause over here, that is called as the diuretic use. Okay, certain diuretics, the loop diuretics like furosemides, guys, like in pharmacology you will be like studying all this. Thiazide diuretics, basically they cause loss of potassium and hydrogen through the urine. Okay, Now, what will happen if the hydrogen is lost? There will be a decrease in the hydrogen ions that are circulating, and it will contribute to this metabolic alkalosis, right? So that is something you have to remember. Okay. Now, that is, yes, metabolic alkalosis. Now we have some charts, guys. Let us just try to focus on that. Yes, they have given a question over here again in this. A 58-year-old man develops worsening substernal chest pain after having his dinner. He tells his wife he feels a squeezing pain that is radiating to the jaw and left shoulder. He was taken to the hospital, and on examination, heart rate, you can see it is increased 112, and blood pressure is also increased. ECG shows significant ST changes. The probable diagnosis is myocardial infarction. Whenever a part of the heart, guys, it is like whenever it has a low blood supply, low oxygen supply to one part of the heart, it is called as myocardial infarction over here. Okay. Now, ECG findings, you already know it is ST, so that again gives me an indication that it is the myocardial infarction. Now, when I say, guys, just try to focus on the question over here. It says that substernal chest pain and radiating. This pain is radiating to the jaw and left shoulder. It is a classical finding, guys. It is a classical finding of angina pectoris. It is this angina pectoris, but is no related to this myocardial infarction. High rate, you can say normally the heart rate, it should be between 60 to 100 beats per minute. But over here, the heart rate, it is 112, it is increased. Even the blood pressure, which should be 120 by 80 mm of Hg, it is 160 by 80 mm of Hg. So both heart rate and the blood pressure is increased. Okay, again, indicative of there is something sympathetically active in response to pain or distress that is no coming from this myocardial infarction, right? ECG changes, even ECG changes over here. Remember, it is ST elevation that you have to remember. It will indicate the myocardial infarction, right? ST elevation, STEMI, STEMI, that is ST elevation, basically causing myocardial infarction, right? So that is we have non-STEMI type of over here. We have STEMI type of this. Yes. Coming on to the steps of development of atherosclerosis. Now let me discuss this over here. The steps of, yes, just a moment. The steps of development of atherosclerosis. Now, guys, firstly you have to remember we have the endothelial injury. Endothelial injury. Now you already know the blood vessels. They are basically lined with the endothelial cells. They are basically lined with the endothelial cells, right? The lining of the blood vessels. And this damage can be due to like hypertension. It could be due to smoking, or if there is higher lipid in the blood, hyperlipidemia. So there can be endothelial injury of the blood vessel, the arteries, right? Now the second step will be lipid accumulation. The second step will be lipid accumulation, right? Now what will happen? The low density lipoprotein, okay, the cholesterol penetrates the injured endothelium and becomes oxidized in the intima of this arterial wall. You already know we have the various layers in the arteries, and the innermost, it is the intima. And the LDL, that is the cholesterol, low density lipoprotein cholesterol, basically it will penetrate the injured epithelium and it will become oxidized in the intima of the arterial wall. Then there will be something called as the inflammatory response over here. Inflammatory response. You already know the oxidized LDL, the low density lipoprotein. Basically, it will trigger an inflammatory response. Okay, attracting the monocytes to the site particularly, right? Monocytes over here will be transformed into macrophages, right? monocytes will transform into macrophages, and these macrophages will ingest oxidized LDL, becoming foam cells. Foam cells. Now, what will happen, guys? Obviously, there will be formation of streak. Fatty streak. Obviously, these foam cells will accumulate and form fatty streaks in the arterial wall. Then there will be fibrous plaque formation. Fibrous plaque formation. Basically, the smooth muscle cells migrate to the intima and they will proliferate, producing collagen and other extracellular matrix components, right? Covering a fibrous cap over the fatty streak. And obviously, there will be, at the last, there will be plaque growth and complication will be there. Plaque growth and complication will be there, right? As the plaque grows, what will happen? It will narrow the artery lumen, right? So it may become unstable, rupture, exposing the thrombogenic materials that will lead to the thrombus formation, which can obstruct the blood flow, guys, obviously, and it will cause the myocardial infarction. So that is the steps of development of atherosclerosis. The third question that they are asking, list the biochemical markers that can be used in the diagnosis of this condition, guys. Remember, we have troponin I, and troponin T, right? The second one, remember, okay, troponin I and troponin T, what are these, guys? These are proteins. They are the part of the cardiac muscles. They are the part of the cardiac muscle contractile apparatus, right? Elevation in the blood basically is highly specific to myocardial injury, and it is considered gold standard for diagnosing the myocardial infarction. Then we have creatinine kinase MB, that is, yes, isoenzyme of creatinine kinase predominantly in the cardiac muscle, and elevated enzymes of this creatinine kinase will again suggestive of these, yes, like it's basically less specific than the troponin I and the troponin T, but yeah, it is always. Then we have myoglobin, guys, the myoglobin, right? It's a small protein that binds oxygen in the muscle tissue. So it is released into the bloodstream where there is muscle injury, including myocardial infarction. So it is less specific and is used primarily as an earlier marker. We also have one more enzyme that you can remember, that is lactate dehydrogenase. It's basically involved in the energy production with various isoenzymes. Obviously, whenever there is like less blood supply, obviously LDH will be, yes, indicating the myocardial injury, but it's very, very less specific, guys, over here. So that is about this, you can remember. Now, coming on to the next question, guys, is calculate the energy requirement of a average second year MBBS student, guys. You can just like follow the flow chart over here. The total energy requirement, it is basal metabolic rate plus physical activity plus STA, right? It is BMR for an average adult, it is 24 kilocalorie per kg. So considering the average adult weight as 55, BMR will be 1320 kilocalories. So energy basically depends on the type of the walk. So physical activity for moderate worker, it is 40% of BMR, that is 528 calorie, right? So energy expenditure, it will be 1320 plus 528, that will be 1848 kilocalories. So yes, remember the specific dynamic action, it is like coming 10% of this, that is 184 kilocalorie, and total energy requirement, it is BMR plus physical activity plus specific dynamic action, that is 1848 plus 184, that is 2032 kilocalories. Coming on to the next question, guys. A 2-year-old boy was brought to the hospital. He was eating poorly for the last 1 month and has intentional diarrhea, had become irritable and apathetic. On examination, he was underweight for height and small for age. He was pale, weak, skin was flaky, hair was brittle, abdomen was distended, liver was moderately enlarged and generalized, edema was present. So hemoglobin, it is, you can see it is 6.5, very, very low. Total protein 4 and albumin 1.8. What is the diagnosis, guys? It's already given Kwashiorkor. Okay, so basically you already know kwashiorkor results from a deficiency of dietary protein. Deficiency of dietary protein, right? Which disrupts several physiological functions. Now, over here, you can see that we have low levels of albumin, right? So let us discuss the pathophysiology, guys. We have hypo hypoalbuminemia, right? Protein deficiency will lead to a reduced synthesis of albumin in the liver, right? Consequence, guys, you already know albumin is very crucial for maintaining oncotic pressure, right? It is important for maintaining oncotic pressure, and we have already discussed this in our normal lectures as well, right? So obviously, if there is a decreased oncotic pressure, it will lead to the fluid in like excretion in the interstitial spaces, and that will be something which will lead to edema, guys. So you can see the abdomen was distended, right? So generalized edema will be seen in the patient. Edema formation will be there, guys. There will be edema formation, and we have already seen why, because there is decreased oncotic pressure. Okay, serum albumin decreased, which will result in decreased oncotic pressure. Okay, now it will, okay, allow fluid to accumulate in tissues, okay, causing swelling, and that will be leading to this edema, right? The fluid will leak out of the blood vessels in the interstitial spaces, and that accumulation of fluid in the interstitial spaces will be presented as edema, right? Then we have impaired immune function. Impaired immune function. Okay. So yes, obviously protein deficiency compromises immune function, right? So the child will be like more susceptible to more diseases, right? We also have hepatomegaly, guys. Hepatomegaly, the liver. Okay, now what liver in turn will try to do? Liver will try to increase the size, guys. Yes, liver will try to increase the size by coping up, because already the proteins are less. So yes, leading to fatty infiltration and enlargement of the liver. And fatty liver can result from improper fat metabolism. And yes, we can have the dermatological changes as well. Dermatological changes as well, which you can see over here, right? You already know the skin becomes flaky, is already mentioned in the question, right? And yes, dermatitis can also be seen, even the pigmentation can be there. Okay, so deficiency of proteins will always affect the skin integrity and regeneration. We also have growth retardation, guys. Growth retardation. Growth retardation. Basically, inadequate protein intake, what it will do, it will impair the growth, okay, development, leading to stunted growth and delayed milestones. So yes, that is something you have to remember about kwashiorkor. Coming on to the next question, guys. They say, yes, an 8-month-old infant was brought to clinic in irritable state. Weight was much lower than expected, mid-arm circumference, and yes, the triceps thickness are very low for age. Her serum albumin was normal. Mother tells that she had stopped breastfeeding at the age of 6 months and was not tolerating any food preparation. What is the most probable diagnosis, guys? Marasmus, मरा हुआ बिल्कुल, right? Marasmus, right? Now the key indicators. What are the key indicators that you can find over here, guys? You can see irritability, right? The very first one, irritability, right? So irritable, basically it is commonly in malnourished infants due to discomfort in the or due to discomfort and nutritional deficiencies. Now, when I say significantly low weight, okay, we have like mid-arm circumference low, and you can also see the weight was much lower than expected. It reflects, guys, the caloric deficiency. Okay, the lower mid-arm circumference, the triceps thickness is reduced, indicates wasting and muscle loss. So it indicates wasting and muscle loss, right? And normal serum albumin, obviously, unlike Kwashiorkor where serum albumin is low, over here the serum albumin is very, very much like fine. Okay, so because over here the problem is the malnutrition affects overall energy intake rather than the specifically protein part. And in the like former part, like that is yes, the Kwashiorkor, basically the serum albumin is decreased. So yes, what is the pathophysiology of this condition? You should remember that there is a calorie deficiency for sure. We have a caloric deficiency, guys, right? So there is inadequate intake of calories, including both carbohydrates and fats, right? So basically results in body using its fats and muscle stores for energy. So what will happen? Obviously, if the fat is reduced, what will happen? It will lead to weight loss, muscle wasting, and there will be a reduction in the subcutaneous fat. Muscle wasting is again one of the pathophysiological condition that you can remember. Muscle wasting. There is fat depletion, guys, right? Fat depletion and the normal serum albumin, right? That is again you have to remember. So there's generalized wasting and growth failure. Again, one of the more you can remember, that is generalized wasting and growth failure. Right. Now coming on to the next question, guys. Yes, we have like so many cases today. A 42-year-old male without any significant past illness comes to the general medicine OPD for routine master health checkup. His fasting blood sugar was 204. So obviously it is indicating diabetes mellitus. It should be like less than 100. Urine was positive for sugar. HbA1c was 8.1. It is diabetes mellitus, guys, right? You can very well see the fasting blood sugar, it should be like less than normal. I mean, less than 100, right? It is 204. So yes, if it is more than equal to 126 also, it is like, or we can say dietary control and poor like sugar intolerance is there. So yeah, he has to do dietary control, exercise and all to like maintain the sugar. Apart from that, guys, yes, obviously it's saying that urine is positive for sugar. So we have, yes, the glycosuria, right? Which is common in diabetes, and 8.1 HbA1c. HbA1c basically measures the three like months of like sugar intake average. And you can see the normal, it is basically between 4 to 5.6. Over here it is 8.1. It's like severely increased. It's poor glycemic control, guys. Poor glycemic control in the last 3 months. So that is yes, which you have to remember over here. That is diabetes mellitus. Coming on to the biochemical basis of the other um, disorder, you first have to remember we have insulin resistance. Insulin resistance, right? So cells become like less responsive to insulin, right? A hormone that facilitates the extra glucose intake into the cells. So reduced glucose uptake, the glucose will be remaining in the, yes, the blood vessels only, and which will lead to this diabetes. It can be second one, that is insulin deficiency could be there, right? The pancreas may not produce sufficient insulin due to beta cell dysfunction. You already know the which cells of the pancreas produces insulin, that is the beta cells. And if there is any beta cell dysfunction, guys, it will automatically lead to this diabetes. The third one, guys, remember increased gluconeogenesis. Gluconeogenesis. In diabetes, the liver may increase glucose production. Obviously, you know, the glucose is not in the cells. The cells is automatically having not glucose. And if you are not taking any diet from mouth, obviously the liver will think there is no glucose in the cell. So it will automatically increase the production of glucose from like non-carbohydrate substrates, and automatically the glucose levels will be increased. The fourth one, remember, there is impaired glucose utilization. Okay, the lack of effective insulin action basically prevents proper utilization of these glucose by the peripheral tissues. right? So there will be like elevated excess glucose in the bloodstreams, which will be contributing to hyperglycemia. Glycosuria, that is one again thing you have to remember. The long-term complications of the above disorder, the very first one, remember, we have the cardiovascular complications. Cardiovascular complications, basically the coronary artery disease, the arteries which supply the heart, okay? It can be like one of the complications, even the myocardial infarction, stroke, peripheral vascular disease, right? So chronic hyperglycemia will accelerate atherosclerosis. Obviously, we have discussed and cause endothelial dysfunction. We can have neuropathy also, guys. Neuropathy, right? Peripheral neuropathy, like pain, tingling, numbness in the extremities. Okay. Autonomic neuropathy can also be there, for example, digestive issues, or it can be bladder dysfunction. Now, chronic high blood sugar levels will damage the nerve fibers and it will be automatically interfering with the nerve function as well. Retinopathy can be there. We can have retinopathy. We can have nephropathy, right? Kidneys can be at stake. Retinopathy, obviously, diabetic retinopathy, which can lead to vision loss and macular edema, guys, right? So, yes. So, hyperglycemia will lead to the damage in the retinal blood vessels and automatically result in leakage, swelling, and new vascularization is seen over here, right? So, that is something you have to remember over here. What are the long-term complications, guys? The long-term complications, you can just remember, we have already like discussed all this. Yes? No. Coming on to the next question, guys. Yes. A child was brought to the hospital with complaints of generalized edema and decreased urine output. His blood reports are as follows. Total protein it is given, right? 4.8, albumin 1.2, cholesterol 320, it's increased. Yes, urine protein 10 gram per day. The diagnosis, it is nephrotic syndrome, guys. The diagnosis, it is nephrotic syndrome. Yes. Now, guys, you already know that generalized edema. Okay, let us just try to highlight how we actually clinch to the diagnosis over here. The generalized edema and decreased urine output will automatically, it's like a hallmark feature of nephrotic syndrome. Now, if we see the serum protein levels, right? The serum protein levels, you can very well like focus over here, guys, that the total protein, it is 4.8. Normally, it should be 6 to 8. It is 4.8, so it is decreased. Albumin, it is 1.2. It is also decreased, guys, right? Cholesterol is increased. Normally, the cholesterol should be less than 200 milligram per deciliter. Hypercholesteremia, you can see, and it is often associated with this nephrotic syndrome. Even the urinary protein that is 10 gram per day, it is like normal. It should be less than 150 milligram per day, right? The normal it is 150 milligram per day. Okay, you can see it is 10 gram per day. Okay, which is like very, very, very increased. So it is significant proteinuria, which you can see over here. Significant proteinuria, and that is again suggestive of this nephrotic syndrome. Coming on to calculation of this AG ratio, guys, you already know how to calculate the globulin first. Okay, firstly, you already know the globulin, it will be total protein minus albumin. Total protein, you already know we have 4.8. Okay, and albumin, it is 1.2. So globulin will be 3.6. So AG ratio, it will be albumin is 4.8, globulin it is 3.6. Yes. Sorry, albumin it is 1.2 and globulin it is 3.6. So the ratio will be coming out to be 0.33, right? So that is something you have to remember. Now, give the reference range for serum total cholesterol level, but I have already told you it should be less than 200 milligram per deciliter, right? And normal urinary protein excretion per day, remember it should be less than 150 milligram per day, right? So what are the expected changes, guys? It's not mentioned in the electrophoretic pattern. We already know it is, yes, hypoalbuminemia, right? Increased lipoproteins, okay? Normal or slightly increased globulins can be there, right? Now coming on to the next part, guys. Coming on to the next part. A 12-year-old boy comes to the OPD with complaints of swelling in front of neck with prominent eyes. His mother gives history of weight loss. Boy looked anxious and restless. On, yes. Okay, boy, on examination, heart rate was 140 per minute and thyroid gland was enlarged, right? Lab findings, right? Free triiodothyronine, it is 2 to 4 tetra, it is 0.9 to 93 to 1.7. TSH, it is 0.27 to this, right? Now, what they have asked, right? Okay, probable diagnosis guys over here. The probable diagnosis guys over here, they are suggestive of hyperthyroidism, and it is like primary hyperthyroidism. Hyperthyroidism. Now, guys, how can you see? You can see that there is swelling in front of the neck. Okay, let me just. There is swelling in front of the neck. There is swelling in front of the neck with prominent eyes. Prominent eyes basically exhibit exophthalmos, guys, right? Which is commonly associated with Graves' disease, right? Again, in Graves' disease, there is excessive production of the thyroid hormones. We have weight loss, guys. Weight loss, basically, it is common in hyperthyroidism only. It is common in hyperthyroidism only, right? Due to increased metabolic rate. Weight loss, it is due to increased basal metabolic rate, right? Elevated heart rate, guys, right? It's tachycardia, you can see over here. Tachycardia, which is again a symptom of this hyperthyroidism. And if we talk about the values, guys, which is given in the question, now, yes, 5.3, if you can see the normal values, guys, it is 2 to 4.4. The free tetraiodothyronine, it is 5.3, it is also increased. T4, it is also increased, okay, and TSH, yes, guys, TSH, it is 0.27 to 4.2, right? And it is like slightly decreased over here, right? So yes, name the trace element and amino acid required for the synthesis of T3 and T4. And remember, guys, the trace element over here, it is iodine. You already know it is iodine, which is required for the synthesis of T3 and T4. And amino acid, it is tyrosine, required for the synthesis of thyroid hormones, okay, where it combines with iodide to form T3 and T4. Now, what are the expected changes in the basal metabolic rate, guys? So basal metabolic rate will be increased, guys. Basal metabolic rate will be increased. Hyperthyroidism increased the basal metabolic rate due to increased thyroid hormone levels, right? There will be increased metabolism. Serum total cholesterol levels will be decreased, guys, okay? Results in lower serum cholesterol levels, okay, due to increased turnover and metabolism of lipids. Coming on to the next question, guys. Coming on to the next question over here. Yes. From the values given below, calculate the creatinine clearance. I think we have done this in the last class also. So I have just include all this creatinine clearance in the last class as well, right? Yes, I'm not discussing this because we have discussed in the last section. Now coming on to, yes, the other parts of the question over here. Yes. So we have already discussed one of the components, the charts and the cases over here, which are like typical over here. Okay. The acid base also graphs and everything like are being discussed over here, right? Now let us just try to focus on other parts as well. Okay, we have like instruments that can be given, that is pH meter, urinometer, or calorimeter, right? So remember, you have to first identify the instrument, right? You have to, the normal pH of the blood urea, it is, you have to remember for the blood, it is 7.35 to 7.45, and for the urine, it is 4.5 to 8, usually around 6 average. Henderson's Hasselbalch's equation, you already know pH is equal to pKa plus log salt by acid. If the hydrogen ion concentration of gastric juices 10 raised to the power minus 2, calculate pH. So pH is equal to minus log H plus minus log 10 raised to power minus 2, it will be 2, guys. So that was about pH meter. Urinometer, firstly, you have to identify the urinometer. The value of the urine specific gravity measured by the above instrument is 1.008. Calculate the correct specific gravity value at room temperature, that is 30 degrees Celsius. So specific gravity is given. Okay, since the specific gravity increases by 0.001 for every 30-degree rise in temperature, so specific gravity at 30 degrees Celsius is 1.008 plus 0.001 into 5. So that will be 1.013. Normal range of specific gravity of urine 1.006 to 1.030. And two conditions in which the specific gravity of urine is increased, it is diabetes mellitus and dehydration. Coming on to the next one, that is the calorimeter. So basically, you have to first identify it. And yes, what is the use, guys? It is to measure the analytes like glucose, urea, creatinine in the body fluids. And principle why it works, it is the Beer-Lambert law. And limitations, it cannot be used to quantify the analytes in colorless and turbid solutions. Right? So that was like this. Yes, calorimeter. Again, guys, you can just read about the electrophoresis and chromatography techniques also, right? All the principles, procedures, right? You should know. Now, guys, that is something we have like performance. That is the OD calculation, right? So glucose oxidase peroxidase method was employed for the estimation of fasting blood glucose levels of the patient. I will be teaching you one. OD of the standard was given 0.07. OD of the test, it was 0.13. Blank, it was given 0.01. Concentration of glucose standard is 100 milligram per deciliters. From the above values, the fasting blood glucose of the patient and discuss it. So you should know concentration of the unknown substance will be OD of the test minus OD of the blank upon OD of the standard minus OD of the blank into concentration of standard. So you already know it. The OD of the test is 0.13, blank it is 0.01, 0.07 it is the standard one, and yes, the blank one it is again 0.01 into 100. So it automatically comes out to be 200 milligram per deciliter. And yes, that is you can just calculate based on this. Again, there is one more simple question that they are asking. The serum creatinine was carried out by Jaffe's method, and the calorimetric readings are as follows. Test standard blank and concentrations are given, and we have to calculate the concentration of creatinine, guys. So yes, again, the same formula you have to apply and you will get the answer. So this is how you can just go on through the calculation part, right? Benedict tests, guys, these are like the practical skills that I think has already discussed with you. Yes, Rothera's test. Okay. So these are like, yeah, the test, the different test, guys. You have to first write the name. Like no need to write the performance or something, but yeah, you should know. Okay. So you should follow all the steps that what is written over here. Okay. Phosphotungstic acid test for uric acid. Take a test tube, right? Hold the test tube by test tube holder. Take 2 ml of urine solution, 3-4 drops of this, 2 to 3 drops of 20% sodium carbonate solution, and see the color change. So that is again, you can just follow for sodium hypobromide test for urea, heat and acetic acid test for albumin, and Jaffe's test, right? Rothera's test for acetone and acetoacetic acid, and Benedict's test, right? So that was all regarding for today's class that we have discussed about the OSPE part, right? We have already discussed about this OSPE part today, right? So yes, we have discussed the major parts, what all can be asked in the practical exams and how to carry out the calculations, the instruments, the techniques, the charts, guys, the acid-base graphs, okay, the diabetes, the normal values you should be like very much thorough with, right? So that is all about today's lesson on practical class discussion. That is the OSPE part, right? So yes, let's end the session today for today, right? So thank you, and these are the social media handles you can follow for the further upcoming classes. Thank you.